Good evening, everyone. Good evening, all my friends and colleagues from India, and a very good morning to all our friends who are joining us from the United States. My name is INEDSYS, and I'm Director of Hepatology at Medanta Medicity Hospital, New Delhi in India. It's a pleasure and a privilege to welcome you all to this program. Having said that, I think it is sad and unfortunate that we are having to connect for this reason, which is the raging epidemic of COVID-19. This is clearly the biggest medical, social, and economic challenge and crisis we have seen in our lifetime. Well, hopefully, we are seeing that the worst is maybe getting over, and we may have better times to look forward to. But one thing is for sure, our life will change, the way we live and the way we work. Since all of us are hepatologists or transplant professionals, it is important for us to understand how we're going to manage liver disease, how we're going to manage liver transplant recipients, what are the precautions we need to take, and how we will proceed with liver disease and transplantation. So this is what we're going to be discussing in the next hour or so. So why is COVID-19 and liver transplant so important? We know that COVID-19 can be a multi-system disease and there is liver involvement. There is a huge impact of COVID-19 on liver transplantation because of the logistics and the complexity of the surgery. There's a lot of preparation needed in liver transplantation, and there are issues like should we test the donor or the recipient for COVID-19? How do we test them? What are the modalities? How do we protect the team? Do patients who are sick, who have decompensated liver disease, who are immunosuppressed, do they present differently? Do they have different clinical features? Is their prognosis different? All these issues need to be addressed. How can we prevent COVID-19 infection in the post-transplant recipient? How to manage and treat the infected recipient? Is immunosuppression different? Do we need to reduce the dosages? Are there drug interactions? These are many questions which need specific answers. And we have a galaxy of faculty who will, in the next hour or so, help us in answering these questions. Let me introduce our faculty for today. The first talk will be given by Professor Arvinder Soin. Dr. Soin is the chairman of Transplantation and Regenerative Medicine at Medanta Hospital, Delhi in India, and he will be talking on COVID-19 and liver transplantation. I would also like to introduce Dr. Sanjay Satpathy, who is assistant professor, associate professor, and medical director at the in liver transplantation at the North Shore University Hospital, Northwell Health, USA. Sanjay is a very close friend, and he will be talking on pre and perioperative care in this COVID-19 epidemic. It's indeed an honor to welcome and introduce Dr. Thomas D. Schiano. Dr. Schiano was my mentor when I was a fellow at Mount Sinai, and I'm very happy and honored to be introducing him today to this gathering. Dr. Schiano, or Tom, as he wants me to call him always, is medical director of liver transplantation at Mount Sinai Hospital in New York. And he is, I think, amidst all of it right now, and probably has a huge experience in seeing COVID-19 in liver disease and transplantation. I would also like to introduce Dr. Louis Tepperman. Dr. Tepperman is serving as Vice Chairman of Surgery and Director of Transplantation at Northwell Health System, and he will be discussing a few cases with us, which are real cases relevant to COVID-19 and liver transplantation. And finally, I would like to introduce Dr. Ajay Duseja, who is also an expert panelist today. Dr. Duseja is professor of hepatology at the Department of Hepatology at the PGI Institute in Chandigarh, North India. And Dr. Duseja has vast experience in treating liver disease patients and will take questions on managing COVID-19 and this situation in end-stage liver disease. This is one of my favorite songs from school days. We Are the World, USA for Africa. This was sung by a number of American artists in 1985. And I think this is so apt today. We must unite when the world must come together as one. There are people dying, and it's time to lend a hand to life, the greatest gift of all. With this, I would like to invite Dr. A.S. Soin to deliver his first lecture on liver transplantation in the COVID-19 era. Dr. Soin, please.
Thank you very much, Neeraj, and good evening and good morning, depending on where you are. And I'd like to thank the organizers for organizing this webinar. Just give me a couple of seconds while I put my slides on the screen. Okay. So this was just to give you a world view of what's happening with COVID infection. All of you are keeping abreast. Suffice it to say that we are quickly inching closer to the 3 million mark of infected cases in the world, and nearly 200,000 deaths. US is inching close to 1 million infected patients, and I think about 52 or 53,000 deaths. And the figures in India are about 27,000 infected with about 800 dead. So obviously this concerns all of us. But while it concerns all of us, and we are making special efforts to make sure that COVID patients are taken care of and healthcare professionals are taken care of, we also know that patients with liver failure of varying degrees and liver cancer are a very vulnerable group of patients. And if they're not treated in time, they will die. If they're not transplanted in time, we'll have a high waitlist mortality, which is why we need to delve into whether we should be doing liver transplants, what sort of patients we should be transplanting, and how we manage these patients if they contract COVID-19. So we all know that 3/4 of these infections are mild. A fourth of them become severe enough to need hospitalization and support. Half of these go to ICU, and approximately half of them die. Unfortunately, we are still losing 6+% of the patients worldwide. We also know that many of the infected people remain well. Most of the adults are affected. The incidence in children is only 2%. But if the person is more than 60, has diabetes or any of the chronic illnesses like coronary artery disease, kidney disease, COPD, is a smoker or is immunosuppressed, the incidence of mortality among all these infected patients is between 10 and 20%. Now, any policy on liver transplantation in the COVID era must depend on the local infection rates. I can't extrapolate what's happening in Spain, Italy, UK, and US. I have to look at my own country, my own region. I have to look at hospital facilities, the ICU beds and staff available, whether we are predominantly live donor transplants or deceased donor transplant system, whether we have the RT-PCR and the antibody tests available, what sort of turnaround times we're talking about, and what's the accuracy that we're talking about. So obviously, you cannot have a single policy across the world, across all hospitals. It has to be individualized, if not to the city and the hospital, at least to the country. So I'll be talking about how the COVID affects the liver, not too much about that, and mainly about how, whether and what sort of patients we should be accepting for liver transplants, both for DDLT and living donor liver transplants, the testing policy among donors and recipients, and what happens if the donor or the recipient tests positive either before or after the surgery. A little bit about PPE for healthcare professionals, anything special in the consent and the technique of donor surgery. We all know that the spike protein attaches to the ACE2 receptor, and that's how it invades the pneumocyte, but ACE2 receptors are also found in cholangiocytes and hepatocytes, so we know that the liver can be affected. I don't know if you've seen this. This is rather a striking example of a couple of Wuhan doctors who literally woke up to find that their skin had turned dark after the virus damaged their liver. But thankfully, majority of the liver damage is not so severe. In mild cases of COVID infection, there's transient ALT, AST elevation which settles. Even in severe cases, there can be a bilirubin and transaminase elevation and an albumin reduction. So people have been, there are at least 2 reports of severe acute hepatitis, but I don't believe anybody's gone into liver failure because of COVID so far. And this damage could be direct viral damage or a bystander kind of hepatitis due to a cytokine storm. Now, the status of performing liver transplantation. According to the ASLD, they say do not postpone liver transplantation because you'll be compounding the pandemic by risking lives of patients who need transplants. And of course, like I already said, you have to account for the local data when considering suspension of transplantation. In our own Liver Transplant Society of India, we have made 2 versions of guidelines. The last version, made about 10 days ago, says that you can accept patients of ACLF and ALF for transplantation and urgent CLD and HCC cases. Now, what's that? I mean, I looked at our own data of the last 200 patients, and 131 of them, that's 65%, had either advanced beyond Milan HCC or AKI or MELD more than 20, or had advanced biliary atresia, ACLF, or ALF, 1 or more of these. So really, you're saying that at least the patients that we transplant, 2/3 of them need doing anyway, COVID or no COVID, otherwise they'd die. And then as far as DDLT is concerned, we decided in our society that both the recipient and donor must be COVID negative, and we would not go ahead with recipients who have to travel, theoretically by air, so they should be able to reach the hospital by road travel. And also donors who have emerged from high-risk situations should be rejected even if they are negative. Now, I did this survey among centers recently, literally a couple of days ago, and basically everybody is only doing 0 to 40% of their usual volume. These hospitals, number 9, all 3 hospitals do 50 to 100 cases a year, and they've done nothing in the last 1 month because of the restrictions and constraints. So in a month, usually you would have 160 to 170 transplants happening in India, but only just under 40% have happened in the last month of lockdown. And the distribution of LDLT, DDLT is usually 2/3, 1/3, but in the COVID times, most of the transplants have been live donor transplants. So the live donor transplant activity has gone down by about 50%, and the deceased donor transplant activity has gone down by 90%. Tamil Nadu and Maharashtra are 2 states in India that have the highest donation rates, and their donation rates have practically dropped to 0. Donation rates in the US have dropped by 80%, and the cadaver donation rates and cadaver liver transplant rates have fallen by about 30% in the US, and the LDLT numbers have fallen by 67%. Spain, again, their donation rates have come down because the coordination teams working in ICU are too busy with COVID patients, and in any case, COVID clinical compatible cases are not accepted for donation, even if they test negative. The same thing that I said for the LTSI guidelines. So there is reduced availability of beds, and that's why the numbers, as you can see, have dropped from there to about 1/4 in terms of deceased donor liver transplants. This is from Marina's presentation at the ILTS webinar about a week ago. Now, PPEs, it's standard across the world that all healthcare workers in the OR, all kinds of ORs, but especially in the liver transplant OR, must have full level 3 PPE. We also careful to take consents from the patient and the donor, informing them that COVID test could be a false negative test preoperatively, and they could possibly get it postoperatively with a higher attendant morbidity and mortality. Now, that's obviously a concern in the case of the live donor, but this is something that has to be included in the consent. We are avoiding robotic and laparoscopic donor hepatectomies. This is what we've decided as a society, and there is similar feeling across several endoscopic societies. We test all live donors and recipients prior to transplant with RT-PCR twice before the liver transplant, the last one having been done as close to the transplant as possible. For the deceased donor, we obviously do one RT-PCR test when it is obvious that they will be a donor, they will be a cadaveric donor. One could also look at a HR-CT of the chest to pick up early signs, just a corroborative evidence of COVID if they test negative. And you could possibly take a bowel sample because they're intubated. Some people have suggested that when you do a live donor liver transplant, you could do intraoperative donor and recipient tracheal aspirate sample if they've been negative before the surgery. Obviously, this will not stop the surgery, but this will warn us in case the sample comes positive. It will warn us how to manage them postoperatively. And healthcare professionals are not universally tested at this point in time in India, although all admitted patients are tested in most hospitals in India. And healthcare professionals are tested only if there is contact or symptoms. This is a policy that I kind of picked up from the British Journal of Oral and Maxillofacial Surgery. And what they propose is logical once there has been a degree of infection rate in the population and there is major community transmission, then it would be logical to do PCR and antibody testing. And if antibody is positive, PCR is negative, you obviously think that the patient is immune, go ahead, do nothing else. If the PCR is negative, antibody is negative, the patient is at risk, you do the surgery, but then you keep testing them later. PCR positive, antibody negative, obviously you postpone the surgery. Now this assumes that there is good specificity of the antibody test, which may not be the case. Also that all IgG antibodies are protective, which also may not be the case. So this is not entirely incontrovertible. If you find that the donor or the recipient are positive before surgery, then obviously you cancel the transplant and treat as per COVID guidelines of the hospital. The recipient can have the recipient surgery, that's liver transplant, after COVID recovery and 2 negative tests. But a live donor who's tested positive, I think according to the present evidence, can never be a donor, because even if they recover, we don't know if they are carrying small amounts of virus. That will be a risk to themselves and to the recipient. If the deceased donor is positive, this is almost never acceptable, except if you're using the liver for an acute liver failure patient who's otherwise going to die in a day or two. There is no documentation of donor to recipient transmission as yet. What about a recipient who has ALF who is tested positive? I'm not sure if any has been done in the world, but I would personally not accept such a recipient. What's the collateral damage of COVID in liver transplantation? Obviously, the numbers are down, the waitlist mortality is up. DDLT and LDLT are now being done for sick patients with obviously worse results. Blood product availability is a huge issue. Donations are down. Worse outcomes, again, because the patients are sick. And also, if they test COVID positive, then there is an extra 20% mortality. We all know that, especially among admitted patients. Minimal access donor surgery has been stalled. Cost of liver transplantation has increased because of extra tests and PPE for the staff. Fellowships and training obviously has been delayed. Research on other things has been stalled. Hospital revenues are down. Now, this is some registry data from 2 registries, Secure Cirrhosis and COVID HEP. And basically, they look at all liver disease patients and liver transplants who test COVID positive. So among the cirrhotic patients, those who got admitted in the hospital had 40% mortality so far among 118 patients. Among chronic liver disease patients without cirrhosis. Among 50 patients, there was 12% mortality. And among 37 liver transplant patients who were admitted with COVID infection or developed it during their postoperative recovery, there was 22% mortality, which kind of ties in with 1/5 mortality of all patients of COVID who become sick and and need admission to hospital. Now, in terms of pre and post-transplant outpatient management, I'm not going to touch much on this because I think that Sanjay is going to talk about this. But basically, you avoid personal visits and just do telemedicine and visits only when essential. And for post-transplant patients, social distancing at home must continue, and they must have a long 90-day drug supply so that they don't have to step out. For stable post-transplant patients who do not have COVID, nothing changes except they have to emphasize prevention. And for patients after transplant who have COVID, well, it seems that they may not be at a high risk for severe COVID. Data from Spain showed that none of the 13 that Marina talked about in the recent ILTS webinar died. 92% had mild and 8% severe. There was another report from Spain that said that there was nearly 27% mortality in solid organ transplant patients, but only one of these died among the 6 liver transplant patients. And all but most of them were more than 65 with comorbidity, so you can't make too much of these results. Bergamo, Italy, where it's all happening or happened in the last few weeks, only 3 of the 200 liver transplant recipients tested were positive, and none of them were severe. So that's where we are with the evidence. More than 60 years of age. I mean, patients who are immunosuppressed or post-transplant who are more than 60 are more likely to get COVID. And the other problem with them is that because of the immunosuppression, they may have prolonged viral shedding. So there could be what are called super spreaders. And if the general feeling is that with liver transplant with COVID-19, you reduce immunosuppression in most cases, especially the anti-metabolites. And if there is severe COVID infection with pneumonia, then you probably stop most of the immunosuppression except a low-dose steroid. I won't talk about the post-transplant, managing the post-transplant recipient, but that's going to be covered. What if the donor turns positive post-operatively? Well, we are really worried about that. I know of one instance where the donor, recipient, and the surgeon tested positive. The donor and recipient recovered. Surgeon was on ventilator until about a week ago. I'm not sure what's happening. So obviously, there is a huge risk of a patient who's undergoing surgery for whatever reason, if they are in the incubation period, or if they have the infection, if they've had a false negative test. There has been evidence of some viral RNA being found in blood of donors, so that could be responsible for donor-recipient transmission, but it's not been reported so far. This is just to give an overview of what's happening on the treatment front. This is, as you all know, is the virus. That's the spike proteins, and they attach to the ACE2 receptor. And depending on where these drugs are acting, they could be neutralizing antibodies. They could be there is a cytokine storm that happens in majority of the moderately severe patients. And it's not just the viral cytopathic effect, but it's also the cytokine release syndrome that causes the ARDS and multi-organ dysfunction. So anti-IL-6 receptor antibody, that's tocilizumab, can be one solution, which has been used effectively on compassionate basis. RNA polymerase inhibitors like remdesivir, favipiravir, and ribavirin. Protease inhibitors like lopinavir, ritonavir, and of course, you all heard about chloroquine and hydroxychloroquine, and I think they're soon going out of favor. Now, if you're thinking of using antivirals, they have to be in the viral phase, which is the first 10 odd days. And then when the cytokine release syndrome supervenes, then you're mainly looking at tocilizumab. People have tried pulse steroids. That's very controversial. And plasma exchange has been tried. And somewhere around here, convalescent plasma therapy between day 7 and day 20. So I'll summarize now, saying that liver transplant activity should and would obviously depend on the local infection rates. Continue transplanting sick and HCC patients. The lower the infection rates in the region, the more the numbers can be near normal in terms of number of liver transplants. There is a risk to the live donor if he or she tests positive later. 2 RT-PCR tests are a must for all donors and recipients in living donor liver transplantation, one having been done just the day before surgery. Deceased donor transplantation is acceptable if the donor is negative and not from a high-risk area. COVID infection in stable patients, incidence is probably the same as non-liver transplant patients, and death rate is similar, about 20% of moderate and severe patients will die, especially the ones who have comorbidity or are older than 65. So for moderate to severe cases, there is sense in reducing immunosuppression, especially the antimetabolites. Thank you very much for your attention.
Excellent overview. And telling us the impact of COVID-19 on liver transplantation and how to go about transplant in the present times. We'll take the questions in the end. And now I invite Dr. Sanjay Satpathy to talk to us on pre and perioperative care of the recipient in the COVID-19 era. Dr. Sanjay, please.
Hello. Good morning to those my professional colleagues from USA, and good evening to those from India. The slides, please. Yeah. So I've been assigned to talk preoperative and perioperative care of the liver transplant recipients during the COVID-19 crisis. Dr. Soin gave a very elegant talk covering most of the perioperative care of the liver transplant areas, and Dr. Skiana will be covering the post-transplant. So I'll focus mostly on the preoperative, and we'll make discussions around the perioperative care during our 30 minutes panel discussions as well. I have no conflicts. So just to summarize, this is the timeline that you can see how this pandemic started. The first case was detected or reported in December 2019. And since then, in USA, UPC, the first case was reported in Washington State in January 21st. And we have seen a surge of these cases worldwide. And this is where we stand today. You see, the entire world has been grappled with this crisis. And WHO has declared this as a pandemic, and we're all dealing with these cases at this point. Now, having said that, New York in USA is the epicenter of the COVID-19 crisis, and of those epicenter, where I am currently practicing as Northwell Health, is the epicenter of the epicenter. And as you can see, this is the case rise of the surge of the cases that you can see in the New York State. This was a slightly older slide about a couple of weeks ago, but you can see 21,000 cases reported at that time, 20% of the New York State, 10% of the US, and 1.2% of the world is in our health system where I'm currently working. So we have a huge number of patients burden of COVID-19 that we've been seeing, and majority of our staff has been redeployed as a hospitalist to work in different areas to help our manage this crisis. We had to temporarily suspend our transplant program in order to pave the way for these sick, needy patients who need ventilators. And in fact, we have tore down our auditorium to make way for patients' bed and temporary areas has been curbed to accommodate these patients. So this is an infectious disease, very highly infectious or contagious disease, but has an implication in a number of organs. It's including gastrointestinal, liver symptoms. It can cause, of course, the viral entry is through primary presentation is a respiratory symptom, acute respiratory distress syndrome, but as you can see, it has implications in almost every organs. And that is why this and all the societies are working together to find out ways and means how to tackle this condition. Now, liver disease and liver dysfunction has a role that we need to understand here. Particularly in this novel SARS coronavirus infection, you can see many patients has underlying chronic liver disease, and how these patients present and how they will the course of their illness will be affected by having an underlying liver disease is still very early. Our understanding about this is still very early, and there are reports coming up, and as you can see, this has been summarized here. And majority of these patients do develop AST and ALT elevations, and bilirubin elevation is very rare. So what is unclear at this time, whether liver test alterations are a sign of pre-existing liver disease in patients with a more severe course of infection, whether they rather reflect a liver damage caused by the virus itself, or whether they mirror a severe inflammatory response, and whether acute liver injury portends to a poor prognosis. These are not clear. We have seen some reports that Dr. Soin also mentioned about acute viral hepatitis presentations, but none has specifically been reported as related to an acute viral hepatitis related to COVID-19 so far. This is a recent study that our hospital, from our Northwell Health, one of the largest network in New York, who published experience of 5,700 patients that were hospitalized with COVID-19 in the New York City area, just published in JAMA. You can see the AST elevation was almost 58.4%, and the ALT more than 60, as a cutoff more in 39%. So it's the liver function or test abnormalities are quite common in these patients. And currently more work being done with regards to how this affects their outcome, etc. This is a report from from China, where they have shown that from the onset of symptom, and to the time of presentations, if it is prolonged, they are more likely to develop hepatic injury. And so the liver injury is more common when the duration of symptoms is prolonged, and this is what is summarized in this figure. And looking at the presentations, looking at the type of presentations, if you look at the severe versus non-severe cases, those with a severe infection, if you can see in this particular figures on the left side, the blue one represents the confirmed cases, and the abnormal liver function is presented by the red column, and the gray column represents the liver injury. So you can see patients with a more severe liver injury are more likely to develop liver test abnormalities. We also need to be cognizant of the fact many of these patients are also different medications, and you can see on the right side of the panel, particularly drugs like lopinavir and ritonavir has been shown to cause more liver test abnormalities when they are on this. The mechanism of liver injury has been primarily thought to be like a bystander hepatitis related to cytokine storm syndrome. However, direct cytopathic effect has been postulated as well, especially because the cholangiocytes is enriched. Data from 2 independent cohorts has revealed a significant enrichment of the ACE2 expression in the cholangiocytes. And going to this cholangiocytes receptor, the cholangiocyte has the ACE2 receptor enrichment, how that affects, you can see that ACE2 actually, after being activated by TMPRSS2, it attaches to the ACE2 receptor, and these ACE2 receptors are significantly enriched in the cholangiocytes as well. But the question is, If it is so, we expect a very high ALP, high GGT level, but that is not something that so far has been reported in this patients who had a significant liver function test abnormalities, and make it suspicious to us that there could be other mechanism by which the liver tests are elevated, or there is a viral mediated liver injury. Does chronic viral hepatitis increase the risk of COVID-19? This has been shown in the study from one of the study that was published in New England Journal of Medicine. You can see that the number of patients in this particular study with the hepatitis V virus infection was 23 of these 1,099 cases. When you compare the disease severity, there was no difference in terms of their severity, whether or not patients has a severe or non-severe infections. So hepatitis, underlying chronic liver disease, has not been reported so far that it does impact, especially chronic liver disease. Now, what about NAS? In our own series from Northwell, as well as the one reported recently from Cornell, you can see the common comorbidities are hypertension, obesity, and diabetes. Almost the same tune: 56% hypertension, 41% obesity, and 33% diabetes. So these are common comorbidities in NAS patients. So question is whether NAS patient with cirrhosis are at increased risk of a more severe clinical course. Well, the answer we don't know, but what we know for sure, these comorbidities drives this their clinical course. And in fact, one study specifically looked whether patients with NASs are high risk. And in fact, what they have shown, this is the 202 patients, of which 76 patients, which is about 37% patient, had NAFLD in their cohort. And what they have shown that patients with NAFLD had a higher risk of disease progression, 6.6% versus 44.7%, higher likelihood of abnormal liver function from admission to discharge, 70% versus 11%, and longer viral setting time compared to patients without NAFLD. So I think we need to understand about having underlying liver disease, specific liver disease, will have an increased risk of the disease course or not. But this is certainly alarming, and we may need more studies to look into and confirm these findings in Western studies. Now, once my focus is a little bit on this pre-transplant care area. So I would like to say, if patients, which group of patients we need to focus for the transplant, because hospitals are now short-staffed, especially transplant centers are grappling with how to manage these patients. There are thousands of patients who are on the wait list that are in different centers, and there are patients who needs an urgent attention. Some of these patients will need transplant, and we can't just say we can't do transplant in those patients. So we have to have a way around. So the way in order to continue working these patients for evaluations is we have to focus on those who had a poor short-term prognosis, and we have to minimize in-hospital evaluations. Particularly, our focus would be on acute and chronic liver failure, patients with a very high MEL score, patients who had hepatocellular carcinoma at the upper limits of Milan criteria. These are patients who needs an urgent attention, and they need to complete their evaluation, be listed, and when and appropriately transplanted in centers who are equipped to deal with this. We should focus on reducing in-hospital liver transplant evaluation, as I said, and reduce the number of consultations in other departments or clinics like ophthalmologic, dermatologic, dental. These are things that can be avoided in hospital visits and should be done as an outpatient settings. Telehealth should be prioritized, and judicious use of laboratory tests should be done in these patients. Again, in patients with compensatory liver disease awaiting liver transplant, we're saying reducing this patient's hospital visits. Primary care doctors should take care of their problems, and we should avoid bringing them to the tertiary centers, where particularly the transplant center and transplant clinic. And our center, we have been mostly practicing telehealth to take care of these patients. And again, we are doing a lab fly, like where the persons are going to their house and doing the level and collecting blood samples and avoid directing patients not to go to different places where there is a crowding and social distancing. We're trying to practice very strictly. So specific consideration for patients who are actively listed for transplantation. So SARS-CoV coronavirus testing should be performed before transplantations in both donors and recipients, acknowledging that negative testing cannot completely rule out infection, as Dr. Soin mentioned, two testing. Again, even if those two testing not necessarily, we have seen even third test have been coming out positive in sometimes, in some cases as well. So again, it depends on how we're collecting those samples sometimes affecting those results. And consent for diagnostic and therapeutic procedures related to transplantation should include potential risk of nosocomial COVID-19, and living donor transplantation should be considered on a case-by-case basis. And this is, again, it should be country-specific, region-specific, and driven by the number of cases locally that you are seeing. So the policies cannot be generalized and has to be specific to the centers where this is being practiced. Patients with hepatocellular carcinoma, their care should be maintained according to the guidelines. Continuing systemic treatment is necessary. Completion of evaluation after for liver transplantation, but consider minimal exposure to medical staff by using telemedicine visits by phone wherever possible. And in patients with HCC, local-regional therapies should be postponed whenever possible, and immune checkpoint inhibitor therapy may be temporarily withdrawn. And the decision on whether to continue kinase inhibitors in severe non-severe COVID-19 should be taken on a case-by-case basis. Finally, decompensated cirrhotic patients with the complications like portal hypertension, ascites, encephalopathy, spontaneous bacterial peritonitis, those treatment measures should be continued, especially patients should be given enough refills so that they can continue without losing those medications and avoid and try to, hopefully we can avoid their visits to the clinic without complications, preventing those. But several drugs has been under trial, but nothing yet has been proven, and we will certainly looking forward to some of these trial results coming up. And we did see some preliminary results from remdesivir and chloroquine, hydroxychloroquine. There is still debate going around and trials are on, and we are eagerly awaiting more results, but so far it doesn't look that we have a promising drugs that can reduce or shorten this disease yet. Thank you so much for your attention. I'll hand over to Niraj Saraf.
Thank you, Sanjay. Thank you.
For the next speaker.
The compensated cirrhotic, the decompensated cirrhotic in HCC prior to liver transplantation. And I would like to invite Dr. Tom Sciano to talk to us on post-transplant care and management through the COVID-19 pandemic. Dr. Sciano, please.
Hi, everyone. Welcome. Thank you for the opportunity to convey to you what we've been experiencing in New York. I mean, right now there's a dearth of published literature on post-transplant outcomes in patients. I would tell you, though, to check your PubMed on a daily basis, because new citations are coming out very often as our colleagues try to publish their data and help us manage these very sick patients. So New York is, as Sanjay said, is the epicenter of the infection right now. In New York City, specifically, 11,500 patients have died related to COVID infection. At one point in time, the 8 hospitals of the Mount Sinai system had over 2,000 hospitalized COVID patients. So unfortunately, we have seen the surge here. Some of us have been deployed. I've been doing shifts in our dedicated transplant ICU. So it's been a stressful environment, especially for our patients who who are really scared after their transplant, and we try to reach out to them and tell them to just be in contact with us. So some of the published data that we have to help guide us, some of it comes from the previous SARS and MERS epidemics, where it was found that post-transplant immunosuppression was in fact not a risk factor for mortality. As Dr. Sowen said, general recommendations for our post-transplant patients are the same common sense preventative precautions: no travel, hand washing, social isolation if at all possible. The cogent recommendations for immunosuppression are, if you have an asymptomatic COVID positive patient, try to minimize prednisone if they are on a high dose. In the setting of active disease, I think it is prudent to lower your Cellcept, your azathioprine, and your calcineurin inhibitor at least half the dose. From our experience in the setting of severe disease, stopping the medications is prudent, and I would say that that also includes mTOR inhibitors. A lot of our patients who are hospitalized are getting various therapies, and I would caution everyone about the potential hepatotoxicity of these medications in the post-transplant setting. Both Zithromax and lopinavir, ritonavir clearly can affect calcineurin inhibitor metabolism. Both have been associated with drug-induced liver injury. In the New England Journal of Medicine article on remdesivir, there was approximately a 20% hepatotoxicity rate, with 2 patients having to stop the medication due to abnormal liver chemistry tests. And tocilizumab, which is being used for severe cases at our center and in clinical trials across the country, frequent liver chemistry test elevations have been noted. This is a medication that has been used for rheumatoid arthritis. So there have been cases of fulminant liver failure in patients who have hepatitis B with rheumatoid arthritis who have been receiving this medication. So again, cautious use of these meds. So some theoretical concerns and some remaining questions that are plaguing clinicians. The immune response may actually be a driver for the severe pulmonary injury. So can immunosuppression actually be somewhat protective? There's been a shift in the paradigm of this, I think. So many of us now are seeing that thrombosis is a major problem in these individuals, and what speaks for it being a multi-system disease. Evolving autopsy studies have now shown microthrombi in the liver, in the lung. The ARDS that occurs in these patients with severe lung injury is not the typical ARDS that one sees. And this thrombotic hypercoagulability concept has really taken forefront here in the US. So now many of the patients who are hospitalized in our system receive anticoagulation when they have severe disease. So stay tuned to this. I think this is a very compelling concept. As Dr. Sowen mentioned, immunosuppression may actually prolong viral shedding. It's still unclear if other immunosuppressed patients, such as those having autoimmune hepatitis, actually have increased mortality over and above the patients who have the standard comorbidities. Is the severity of disease based on the type and degree of initial inoculum? So if someone coughs 2 feet from you, are you going to get a more severe disease than if you touch a surface and then touch your face? Intuitively, we would think it is, but there's really no data on this. And Mount Sinai has taken the lead in antibody testing and ramping up antibody testing. And again, the questions are, is this going to be durable? Is this going to be adequate, especially in transplant patients? Are they going to be able to mount an antibody response? So a lot of questions for the future. So some clinical and biochemical manifestations of COVID-19 infection post-transplant. We know that other viral infections can trigger rejection. We saw this with Hep C, with CMV. And now we've seen this in several patients. There's been one report, I'll call your attention to the Lagana publication, where it seems that a COVID infection in the immediate post-op period triggered a rejection. We have seen a similar case here. I call your attention also to the clinicaltrials.gov study where guided immuno-optimization for COVID infections is being studied. So I would welcome this data when we see it. In our post-transplant patients, aminotransferase elevations can vary from minimal to no elevations to 5 to 10 times the upper limit of normal. In the biopsies that have been done, histology shows an acute hepatitis with prominent clusters of apoptotic hepatocytes. Mount Sinai is done approximately 35 autopsies in the deceased with COVID. So we again welcome those findings when they come. All of these patients have markers of inflammation, typically increased titers of D-dimer, ferritin, procalcitonin, and CRP. And there does seem to be data that links prognosis with the degree of elevation and the response of these elevations to treatment. So everyone that is hospitalized here with COVID infection gets all of these markers of inflammation assessed. I would caution you about hydroxychloroquine, for instance. It's got a lot of press. One of the concerns about hydroxychloroquine is that it can increase the QTc. Remember that cirrhotics at baseline may have an increased QTc, and this may persist for a couple of weeks after transplant. So this is an important concept. No one here gets hydroxychloroquine as an outpatient. They only get it as inpatient because of this concern. So again, right now, there's a dearth of published experience in the post-transplant setting, and these studies have already been cited from northern Italy. The Buri study, 6 out of 151 patients became COVID positive. 3 of these died, and as we are hearing all of the time, the presence of the comorbidities is significant. So at the end of the day, we're going to have to decide and try to figure out, is it the immunosuppression that may convey mortality, or is it because these patients have concurrent medical comorbidities? There have been numerous case reports from China showing mixed results of mortality and then success with treatment. The Spanish study was cited where the overall mortality was 28%. Only one of the liver transplant patients died, but I think this was very sobering. And the conclusion was that solid organ transplant patients had a more severe outcome. They were older patients, all had medical comorbidities. They were farther out from transplant. There were complicated issues with the immunosuppression. Lopinavir and ritonavir were used a lot. They had their own problems in terms of managing the immunosuppression. Patients were on mTOR inhibitors as well. So this was a very sobering experience, only a few liver transplant patients. So some other important data points. It may be that patients who have had kidney transplants may be a little bit more risk for poor outcome, especially early on, because they receive lymphocyte depleting therapies. So I think that many of the programs now are, especially in kidney transplant, it's not done a lot in the liver transplant side, are reassessing their need or their resolve to use lymphocyte depleting therapies. In New York, live donor kidney transplant has been in a moratorium for a while, in some part because of this. So I think this is something to assess, and we can learn something from the kidney transplant literature. Unpublished data from our center, 38 patients post-transplant have become infected with COVID, and we have a 13% mortality. Patients infected within the first several months after transplant seem to do less well. And we have 3 nosocomial cases, and we'll touch on that in a little bit. As I mentioned, every other day there's a new publication, and I would call to your attention this publication in the New England Journal of Medicine from yesterday, from one of our institutions in New York, from Montefiore Medical Center, that published their data on the kidney transplant side. And it suggests kidney transplant patients seem to have worse outcomes. Again, sobering data, and we have to tweeze out whether this is related to the immunosuppression in the post-transplant state versus the medical comorbidities that these patients have. The clinical presentation may vary. Patients may have less fever than they ordinarily do when they're not immunosuppressed. And as Dr. Sowen mentioned, there are several registry trials underway in the US. I'd like to convey to you some of the lessons we've learned at Mount Sinai. And, you know, we have been doing transplants through this pandemic, thankfully, successfully so far. And I think one of the reasons we've been able to do this is that we have a non-COVID ICU and floor. We don't say COVID-free because it's very difficult to maintain freedom from COVID in this setting. But we have a dedicated ICU, a dedicated post-transplant floor where the patients are housed in an effort to try to minimize infections. We do transfer patients who have decompensated liver disease to us, and even if they are tested at the transferring hospital, we retest them. Once they enter Mount Sinai, we put them in an isolation room, we retest them, and if they're negative, then we put them into the general population. We have dedicated staff in all of the patient care areas, so no one rotates in and out of the COVID positive unit. So the nurses only work on the transplant floor. The ICU has dedicated anesthesiology residents who are only working there, again, in an effort to try to minimize infection. What we found is very difficult is post-transplant discharge in living situations. You know, in our patients who live in the outer boroughs, Queens and in Brooklyn, there are several generations of family who live in the same house, and it's very difficult to try to minimize exposure and infection. So we're still struggling with this, what to do. We have a hostel for post-transplant patients, but unfortunately we've had to close that, again, because of the risk of infection. So this is a dilemma that we're still struggling with, and right now we just try to minimize the number of people in the house, try to have them quarantine in a separate part of the house if at all possible. As mentioned several times, we minimize office visits and laboratory testing if at all possible. The other thing we've learned is that COVID testing, there are a lot of false negatives that we find. I think a lot of it has to do with the way the swab testing, the nasopharyngeal swab testing is performed. That's what we're doing right now. So we've had a couple of patients who were tested numerous times at an outside hospital, came to us, tested here, and it was positive. So even if someone is negative on swab, if the clinical impression is that they may have COVID, we treat them as if they have COVID in terms of isolation, getting our ID colleagues on board. Post-transplant, we've run into a lot of in-hospital logistical difficulties. Transportation, it's very difficult to get dialysis for some of our patients because I would say that probably a third of patients with severe COVID infections have AKI. Some of them may already have chronic renal insufficiency. So the availability of dialysis can sometimes be problematic. Getting patients to and from procedures, very, very difficult. So we're learning on the fly, and I would just, again, convey to you that these can be issues. There have been some difficulties in terms of patient education about their medications. Even though we're ramping up our telehealth services, it's not ideal. Many of our patients do not have English as their first language. We need to get the family involved. They're not computer savvy. So we're trying to struggle with this on a day-to-day basis. We're trying our best in terms of patient education. And then finally, I think the overall guide is we do not have to preemptively decrease immunosuppression in these patients. I think that we run into problems if they in fact reject, and we have to further increase the risk of infection by going up on the immunosuppression. In our post-transplant patients who've been out from transplant for a long time, we're encouraging them to get the Pneumovax. This is not going to prevent them from getting COVID, but it may prevent them from becoming super infected. In the United States, there's a lot of hesitancy with getting vaccinations. I think hopefully this will strengthen the resolve of patients to get their flu shot. Again, not to prevent COVID, but from getting a super infection. We preemptively been calling all of our patients to talk to them, tell them we're here, to call us for anything. I can tell you, a lot of the patients are really scared at home. They feel isolated. They have a lot of questions. So we're trying to solve that by reaching out to them proactively. We're very lucky that we have a dedicated transplant ID team here, and we involve them in all of the patients who are hospitalized with COVID. They are the ones who vet the clinical trials, and many of these patients may have, again, other complicated infections. So we get ID involved in a timely fashion. There are a lot of experimental therapies that are being vetted here at our hospital and all hospitals throughout the U.S. I mentioned again the discharge complexities we have to deal with, and again the ongoing theme here is that the medical comorbidities, as opposed to the immunosuppression status, that is more problematic for COVID-19 outcomes. My own personal bias is that early on, after transplant, when patients are on a lot of immunosuppression, it does contribute to the morbidity. It contributes to the initial severity of the infection. But someone who's on a minimal amount of immunosuppression several years out, I'm not sure that the immunosuppression conveys additional risk over the medical comorbidities. Thank you very much.
Dr. Schiano, for a wonderful and care and giving your first-hand, real-time experience. I think it is really good and valuable, and I think all of us will learn a lot from that. With this, we end our series of talks, and we will go on to our discussion, which will have some questions and a few case snippets by Dr. Tepperman. Before I go to Dr. Tepperman for the case, I'll just take a couple of questions from our delegates. And Dr. Ajay, can you hear me? Dr. Ajay Duseja?
Neeraj, I can hear you. Can you hear me?
For you. Patients
Hello?
who are pre-transplant who have decompensated cirrhosis, are they likely to get more severe COVID disease compared to a normal person? Would they have a worse outcome, and would their presentation be different?
Neeraj, I missed the initial part. Maybe my audio was not very clear. Can you repeat the question?
A pre-transplant patient who has a decompensated cirrhosis or a HCC, would his outcome if he gets COVID-19 be different from other people? Does he have more severe disease, or does he have a different clinical presentation?
Well, I think that's a very good question. And I think if you look at the some of the risk factors which put you at risk of having severe disease, so there are certain clinical phenotypes, and there are certain lab indicators which can put you at a higher risk. And we are all aware of the clinical phenotypes, the age, the metabolic syndrome, comorbidities, and everything. So there they do mention that the underlying chronic liver disease actually could be a risk factor of putting you at a severe disease. And some of the lab data which suggests that the low albumin, low platelet count, and maybe high ALT could also be at putting you at a risk, suggesting that the underlying liver disease could be putting you at it. Now, what is the data on this? So unfortunately, we do not have large data on this. The only data is which was shared by Dr. Soin are these two registries. And the registry, number one, the secure cirrhosis actually says, and if you look at the, I mean, he said that the mortality, they're around, I think, 110 cirrhotics in that. And they have child A, B, and C. And if you look at the mortality in child A, B, C, actually it is least in child C. So I think the numbers are the issue here. Probably we need more data to answer this question, whether the severity of liver disease has anything to do with ultimate outcome. But yes, underlying liver disease could be a risk factor for this.
Thank you, Dr. Ajay. Dr. Sciano, can you take the next question? We're being asked whether there's a need to decrease routine immunosuppression in the first 3 months after liver transplantation. And there's a thought that you decrease or stop MMF. In that case, would you increase the the TAC dose or the mTOR dose?
I mean, right now, again, in someone who is not infected, we are not preemptively changing our protocol. We do not induce, we do not give induction immunosuppression for our patients. Many of our patients are sick, so they're less likely to reject, frankly, in the early postoperative period. So, I mean, our philosophy is that we try to minimize immunosuppression anyway in these patients, in some part to protect their renal function. So, to avoid becoming infected, we do not preemptively make any changes.
Okay, another question. You talked about the low sensitivity of the swab test, testing prior to transplantation. So do you use a CT scan to help you improve the sensitivity, and what do you look for in the CT?
So we only get CT scans in patients who we suspect have COVID and their chest X-rays are negative. So there are pulmonary people and radiologists feel that the screening X-ray is adequate to look for the sort of typical bilateral pneumonitis pattern. If patients have a normal X-ray and we think they have COVID, they're hypoxemic, for instance, then we will move on to getting the chest CT scan. So chest CT scan is part of routine care for these patients has fallen out of favor. You have to transport them. It's a big logistical issue.
Okay. We have another question. Maybe Dr. Sanjay can answer this. Can COVID infection reactivate hepatitis B? Dr. Sanjay?
And present with a reactivation, causing reactivation of acute hepatitis B. The series that was published, one of the largest series from China, of the 1,099 cases, a very small fraction of those patients has actually, and as I showed in my slides, only 23 patients, 2.1% of them had hepatitis B infections. Of those, in the non-severe case, 2.4%, and in the severe case, only 0.6%. That is one case in the severe case. So it has not been reported that hepatitis B reactivates with COVID-19 infection. So there is no data to support at this point in time.
Dr. Sanjay, again, maybe you can take this. Do you have any experience with plasma therapy in patients post-transplant with the COVID-19 infection? Maybe
I think the data, yes.
Yeah, Sanjay.
Okay. The data is evolving. I think there are very limited data at this. But in our center, we've been there is an ongoing trial. I think we're eagerly waiting more information about it, but we don't have real experience at this time to present a result of this. But certainly this appears promising based on limited study.
Okay. Okay. Dr. Soin, maybe you can take this question on the use of PPE or scrubs during this long surgery, should PPE be worn throughout the procedure, or can it be worn only, when aerosols are being generated, like at the time of CUSA or a pottery? Because it's a long surgery, and so can you just wear scrubs in most of it, or do you need a PPE throughout the surgery?
Ideally, PPE should be worn by all the people present in the OR throughout the surgery. Now, how we are doing transplants on patients who need it urgently. And how we do it is that we're cutting down on scrubbing and de-scrubbing. You just don't take a break. You just do the whole thing at one go. And if you're going to be going off, then somebody else comes in and they carry on and finish the operation. That's as far as the surgeons are concerned. And also the technicians and nurses who help us. So basically, let's say in an 8-hour operation, we have 2 teams who will scrub up, do the first 4, 5, 6 hours, and the last 3, 4 hours will be done by the second team, if that's the way you're planning it. But we do not have changing into the PPE, then going out, then wearing another set. That we are avoiding that. Okay. As far as the anesthetists are concerned, admittedly, there is a screen, and they are at risk when there is intubation or extubation. And at that point, I think, again, if the same anesthetist is going to have to, doing it, then they're going to have to wear different PPEs, right? You cannot have the same guy wearing it 8 hours earlier and then 10 hours later, or 10 hours earlier and then later at the end. So, but if you have 2 people, then, the first guy can be there for the first 4 or 5 hours, and the next person can be there for the next 5 hours. So that's ideal. But in real life, yes, you will find that in an OR where there are 8 people, there'll be 2 who will be not wearing full PPE, then there'll be a couple of people who change in and out. And, so real life is different from ideal.
Okay. There's another question. Maybe you can take this as well. What testing strategy would you use for asymptomatic medical or paramedical professionals prior to a LDLT surgery?
So medical professionals are only being tested if there has been a history of contact or if there are symptoms. And obviously, in either case, we're not letting them into the OR, right? Until they prove negative.
Yeah.
We're not doing routine testing.
Okay. So this is even for hotspots which have maybe a higher incidence of COVID-19?
So maybe Dr. Sciano or Dr. Tepperman or Sanjay would be in a better position to answer that. Because we haven't operated in a hotspot yet.
Dr. Sciano?
What's the question, please? Again?
What would be your strategy for testing a doctor or a paramedical person prior to a living donor or even a deceased donor transplant?
Again, the donor and the recipient are tested for deceased donor. They're tested as soon as possible before a potential transplant. Live donor liver transplant here really has been on hold for the last 3 weeks. So I think that we're planning to sort of reopen in the next couple of weeks, and I think that probably getting 2 tests, one 24 to 48 hours and one right before, is reasonable for both donor and recipient. I do like the idea that Dr. Sowan brought up about the tracheal aspirate during the case, to sort of help us plan, post-op if there are issues in terms of where to house the patient, because we have had a couple of cases of nosocomial transmission.
Okay. Another question, maybe Dr. Sciano, you could take it. You have experience of a number of patients transplant who developed COVID-19 infection. So do you see that their presentation is different? Do they have different clinical features? Do they have, more acute ARDS? What has been your experience?
It seems from looking at our data that they may not present as much with fever as the general population does. You could say that that's ascribable to being immunosuppressed. but really they have the same type of presentations where they're a little short of breath, they're having a cough, they have a fever. There's a lot of awareness now, so these patients are coming in to be evaluated. We find that they have COVID, they get hospitalized, we try to sustain them, and unfortunately some of them have the same inexorable course where they, no matter what we do, they just develop worsening hypoxemia. I think that what I'm going to propose to our transplant team is that all of the patients leaving the hospital go home with a pulse oximeter, because we're finding that there is asymptomatic hypoxemia in patients, and that's why a lot of patients, when they finally make it to the ER, they're in extremis, because they're walking around with O2 sats probably less than 90. They don't feel bad, and then something happens, and then they fall off the cliff. So I think that that's one very simple thing that we're probably going to do for our patients at this time.
Okay. Another question, maybe you could take this as well. We know that there are no approved drugs for COVID-19 right now, but people have used HCQS, remdesivir. Have you used them, and are you aware of any drug interactions with INEDSYS or MMF?
With remdesivir, I am not aware of drug interactions. I mean, clearly they're possible with the Zithromax component of the combination treatment with hydroxychloroquine and with the ritonavir medication. So I'm not aware of remdesivir associated with DDIs. But again, they are associated with drug-induced liver injury, which may complicate the clinical course.
Okay.
I'm back. Sorry
Great.
for being
Dr.
kicked
Zimmerman is
out.
back.
We have seen we have seen some people in the periphery give so they think Zithromax is good, so they think erythromycin is better, and then we've seen people outside, not transplant physicians, giving erythromycin macrolide-based derivatives, and patients going into renal failure.
Okay. Dr. Depperman, since we lost you for a while, we took some questions, and we would appreciate if you could take us through the case snippets which you have, and we could have a discussion on those as well.
Well, thank you very much. I'm sorry for having technical difficulties. As you heard from Sanjay, we are the epicenter of the epicenter. New York has been plagued by this virus. I like to call it plague. At the max, you heard from Tom that his system had so many individuals in their hospital. We've had over 3,200 at one point in time, and our hospital has doubled its ICU capacity, starting from 5 and now having 11. I'd like to give you a little case history and see what the group thinks. This is a gentleman that had his transplant 8 years ago. He had Hep C. He's a white male. We've actually found more disease, more COVID disease and problems in males than females. He's on minimal immunosuppression, and he presents with significant diarrhea and shortness of breath for 2 to 3 days, and elevated temperature. And while I was telling you about this is a good lead for the erythromycin, people in the periphery have been giving, they hear about medications, so they give macroglides, and they can put you into renal failure. So first off, for the group, I'd like to ask the question, have you seen, Tom or Sanjay, a lot of post-transplant patients with significant diarrhea as the presenting syndrome?
Sanjay, can you take that?
In the meanwhile, the patient's creatinine was 9, AST was 18, bilirubin was normal in this scenario, and we routinely get a chest x-ray still. A patient had fluffy infiltrate, so the next question is, O2 sat was 92, and do you get CAT scans? And Sanjay, I see you're back.
Yeah, I'm going to go back to the question on the diarrhea. So we're seeing more and more patients with immunosuppressed patients, particularly liver transplant or kidney transplant patient, presenting with atypical symptoms as well, more severe course. And especially I have seen patients presenting with diarrhea as a primary symptoms, and then the late development of respiratory symptoms as well. And also the question are the two things here with the diarrhea presentation: longer viral setting, but we don't know whether the RNA in the stool is really infective or not. So that's another question. So these are things that is brought up with this issue of diarrhea. But certainly the presentations are more atypical in immunosuppressed patients, and diarrhea could be a presenting feature in these patients as well.
So we've seen that, just what Sanjay said, it's about 15 to 20% of the individuals presenting with diarrhea, shortness of breath, anywhere from 40 to 60%. And in time, 80% of individuals will have a fever and some shortness of breath. In this case, the renal failure was problematic, big time diarrhea, as well as, toxicity. And then if you do in fact do a CAT scan and you see the fluffy infiltrates, Dr. Shiano, I wonder what you think. So this gentleman was on 5 milligrams of prednisone, Tacrol milligram twice a day, and Cellcept, noting that he has, a decreased O2 sat. He's now on 3 liters. What would you do with his MMF? Tom, I think you're talking, but we can't hear you. I'm sorry.
So I think at this point, while hospitalized, I would actually hold his Cellcept and continue the other immunosuppression until we have more data back.
So in fact, you're correct. His Cellcept was held. He was certainly COVID positive. He was hydrated. And so now the question that you brought up before, I thought really on point, anticoagulation. Would you anticoagulate?
Again, it's a tough call. I think that right now our teams are using by protocol heparin and some of the NOACs as part of a study protocol. And from the data that I'm seeing, I think that there's something to this about the hypercoagulability of these patients. There may be some complement activation. So I would anticoagulate them with what? I think it would be based on a protocol.
Right, so it is our protocol to anticoagulate now everyone who comes into the hospital. This has been significant. Certainly this individual has renal failure. As the renal failure gets better, a Lovenox or a Gatroban. But it is now our standard of care, and we concur with you. And we also believe that these individuals are super shedders, and when we tell them to go home, it's really important that they stay away from their family members. I think they're at risk of giving the disease to others. All right, so that's an easy one. Now we have one more, and thank you for helping me through my technical difficulties. The next case study is a 19-year-old African-American female, and we've been seeing this disease in New York hit more of the Hispanics, the non-Caucasians, and being more virulent in that patient population. It may be because of their economic status, or maybe because they don't get health care as quickly as the rest of the people in the U.S. So this young girl was well until 3 days prior to admission. She had some significant aches, mental status changes. She became jaundiced, and now she's obtunded. She requires intubation, and when I saw her, she was intubated. She had a bilirubin of 18, normal creatinine, AST that was sky high, ammonia that was high, and INR that was 5, and a sodium of 133. Interesting enough, her hematocrit was down and the bilirubin was up, and there was in the differential autoimmune and Wilson's disease. And you have to imagine that this is in the middle of 180 people in ICUs being intubated and trying to do care on everyone, and now having someone that has significant and acute liver failure in a hospital system that has stopped doing transplant. So, Dr. Shiano, what would you consider doing before having this patient transplanted? the COVID status is pending?
Well, yeah, I think that I do know this patient. I think this is someone who is going to need a transplant as soon as possible. And I think medical management at this point would be just to stabilize them and hopefully get them transplanted. Again, it's very daunting. And thankfully, there was a lot of wonderful cooperation between transplant centers. So getting a COVID test as soon as possible would be helpful. And then retesting again while waiting for the transplant. I would tell you that unfortunately we had one patient, another patient who was transferred in who had 3 negative COVID tests and had subfulminant liver failure, acute on chronic liver failure. And we transferred them over, we were getting ready to list them, and we tested them and they were positive and confirmed positive again. So
I think you're right on the money. The positive, test, 70% of these individuals will be positive, and the negative test, 20 to 25% of the negatives are truly not a negative.
Correct.
And so the only good thing to know from this testing, the way we do it in the U.S. is the positive. Arvinder, if you're still there, I'd be very curious to know, in this scenario, would you consider living donation, since I still see that you're doing it in India. In the U.S., in the COVID hospitals, we are not, but I'd be curious if you'd consider in this young girl that has acute liver failure.
Yes, certainly. We would consider live donor liver transplant, and we would go by standard criteria of accepting these patients with pulmonary hepatic failure for transplant in terms of the King's College criteria, which she kind of appears to she appears to satisfy. And then obviously these both the donor and the recipient will need the COVID testing prior to transplant.
So it's really a dilemma that you're sitting with, because certainly in the U.S. deceased donation in our areas is just looking at maybe 1/10 of what it was before. So you're limiting your scenario if you don't consider a living donation. You speak about the living donation case in New York, where the surgeon was in fact intubated, placed on ECMO, and placed on dialysis. I'm happy to say that he has now been extubated. But still a long recovery. If you think about it, 3 weeks for any of us, intubated, narcotized, paralyzed, it's a long road back. And you certainly don't want to have a living donor acquire this, come into a COVID hospital. So how would you prevent them from doing that?
I mean, I don't have a straight answer. Nobody has. But the thing is, the attempt is to try and save this young girl who obviously has acute liver failure and needs a transplant. But I think that if the COVID testing is doubtful or not available for either the donor or the recipient, I would not go ahead. So that's for sure. But then I do understand there is a degree of false negativity in the tests, and that's a chance that I guess we'll all have to take.
That we have to take.
Yeah.
Liver that's transplantation started with a success of 25% from Tom Starzl. So there is no question that you're right. Anyhow, it was deemed unsafe for her to be done in a hospital that had closed down and was now ripping out its auditoriums to put more COVID beds in place, and was overwhelmed with over 600 people in the house and 180 intubated.
So also, Lewis, the thing is that you said that if I had the same case in my hospital, in my city, it would be less of a worry. But if I was at Sinai or one of the other hospitals in New York, then obviously I'll think many times before I do a transplant like that.
No. I think you're spot on. So we've also seen in the U.S. Transplant teams, procurement teams, traipse around from a hospital to hospital and actually give 30 individuals COVID. So I think the PPE has to be put into place, and the surgeons have to not acquire the disease and then come back. And in fact, New York was blocked from going out to different regions in the United States because they thought we're like Typhoid Mary or the rats from a ship. But anyhow, we'll go on to this patient. And she was transferred out, so she could acquire her case. And in fact, there was a DCD graft that was available. So now a DCD graft that was too big for her was accepted. Would you take a DCD graft in this scenario?
You see, again, you're putting me on the spot multiple number of times. The thing is that we don't do that much DCD at all. In fact, we don't do any DCD in liver transplantation in India. There have been a few anecdotal cases recorded for kidney transplants. But the thing is that, would you have a machine? I mean, would there be time to run the...
Oh, right. Yeah, no, you're absolutely right. So no machine, no normothermic perfusion. So, but that would be a great idea.
Yeah. So I mean, young donor, less than 30 minutes downtime. Nearly, let's say 2-3 times normal AST, ALT. Yeah, why not? I would.
Okay, Dr. Shiano, I have a question for you. Would you test the surgeons who are going to be involved in this case? Do you think there's a role, or is it important to test the team that's going to be operating on someone?
We do not. I mean, I think for the last several weeks, the institutional policy has been, you're probably positive, regardless. And if you use the standard PPE, which everyone is obligated to do and should do, the risk of iatrogenic transmission is low. So it is not our policy to preemptively test members of the transplant team. Before we enter as a physician into the transplant ICU, we have our temperature taken. So if you have even a low-grade fever, you don't come in. Again, that's a very crude way of trying to protect things, but right now we're not testing all of the surgeons.
So I think when antibody testing is more readily available, we will. I think it's going to be part of our armamentarium going forward for everybody, to be honest. We just tested, just to give you an idea, for individuals that came back to work, about 5% of our workforce was out with COVID. When they came back, anywhere from 10 to 30 days, we tested them for antibody. 87% of them tested positive for antibody. And then if it was after 30 days, then 100% tested positive. So encouraging news. Don't know if it's protective, conveys some immunity. We've just done, and I don't have the answers yet, the staff that's been exposed, the staff that's been taking care of patients in the COVID units or hardest units. We just had 200 people, and I should have those results back, by Monday. All right, so this individual was then transplanted. She was then confirmed to be negative for COVID. I gather that the graft was too big. She needed to be left open, then closed, gone on to renal failure, and then now, how is she, Dr. Shiano?
She's doing much better. She still has suffering from renal failure on dialysis, but slow resumption of renal function. Liver tests have almost normalized. As an FYI, her liver explant showed severe autoimmune hepatitis and submassive necrosis.
So I think this is something that is really important. Everyone says New Yorkers are tough and they don't collaborate. This is an example of, from the largest healthcare delivery system in New York, Northwell, knowing that they were overwhelmed with COVID and sending the patient for the patient's care best to Sinai, which was still able to do a transplant, was still able to have a COVID negative floor to perform the transplant, and hopefully she will do well. And I think on that note, I'm finished with my presentation.
Thank you, Dr. Tepperman, for the nice learning case snippets. I'll just take a couple of more questions. One question, maybe Dr. Tepperman, you could take it, or Dr. Soin. This is from a pediatrician. Are there any special challenges or precautions to be taken for a pediatric transplant, or would it be similar?
So I think that the precautions are similar. You know, Vincenzo Mazzaferro to do better in liver transplantation with the, you know, in the COVID era. I think it's just kids in general do better. Well, we have only, you know, our pediatric hospital, which is really impressive, was turned into an adult hospital because almost no kids came down with it. And so I think that, you know, we wouldn't give a T-cell depleting agent, but they're still going to need immunosuppression, and, you know, they need more immunosuppression. I would continue it, and I don't think they're going to be at more risk. In fact, I think they may be even at less risk.
Okay, thank you. Dr. Duseja, can you come in?
What?
So, you know, there's a question that, you know, most of the discussion we've been having is based out of private sector hospitals. Since you are based in a public government hospital, how do you see this whole situation of COVID-19 and possibly doing transplants at a public, you know, a public facility rather than a private facility, which may have more or a better infrastructure?
Thanks, Neeraj, for asking that question. Actually, I wanted to just get into this. So, I think this is just for the US experts. I think you know the kind of workload we have in our public sector hospital, tertiary care. So this is for the US experts. I think ours is a tertiary care center, and we, in our outpatient, every day there are around 10,000 patients. And in the liver clinic, which we run twice a week, so every day we have around 600 to 700 patients, so which boils down to roughly more than 1,000 patients per week of liver disease, which are all referral patients we see at our institute. Now, even if you take the, you know, the modest a percentage of that, how many actually are of them will fit into, say, ACLF or decompensated cirrhotics with high MELD or HCC, which are, you know, advanced, which would require your urgent attention. And even if you put that as even say 5-10%, there would be around 100 patients, you know, per week of that kind, which obviously come to us, I mean, in routine days, right? So now, since this is all locked down and the, you know, the outpatient even departments are also closed and only the emergency services are working, so we were actually thinking that where are all these sick patients going, and what is happening to these sick patients? And as rightly pointed by Dr. Soin earlier, I think probably we need to look at our waitlist mortality. I think later on, before COVID era and after COVID era. And I think I'm sure that we're going to find a huge difference. Somebody did talk about the telemedicine, and I tell you, our institute is very, very active, and we have the state-of-art facilities for telemedicine. But then there are only very few patients, those who are availing this kind of facility. So now, what is the reason? And we went into that, and I tell you, India is a huge country. And as I said, ours is a public sector hospital. You have all kinds of patients and all kinds of socioeconomic strata. There are patients, those who come to us to show us, those who do not have access to the computers or laptops. What to talk of the tablets? Some of them may just have smartphones, and even if they do have, they may not have a good quality or high-speed internet. So how can they actually have the telemedicine facility? Some of them who are really privileged or are lucky and who are on a kind of, you know, a phone consultation with us on WhatsApp or so, but they are all, I would say, a minority. So what is happening to the larger, you know, population? I think I'll again come back to the point which was made earlier. This is what is the collateral damage. We have to agree that during this COVID pandemic, I think the other diseases, including the severe liver disease patients, I think are suffering, and they could be dying. I think this is for sure. So these are the.
Well, you know, you bring up such a good point, and the poor do pay more in this. My brother runs the large trauma center in New York at Jacobi, and you know, they are They don't have the same PPEs. They don't have the same telemedicine. And you're right, the individuals don't have phones and computers. But you're asking such a good question, which is, what's happening to all the other medicine? Because the people are afraid to come into the hospital. So I'll give you an anecdotal. So we've redeployed a lot of the transplant surgeons. Now they're doing appendectomies. Arvinda would love to know that. So we're doing McBurney incisions because no one's using a laparoscope. And we found that everybody is perforated because they've all waited at home and not come in because they're so afraid. So they're all coming in with whatever disease. The appendix is just an example, much sicker. We've just turned the corner. So at Northwell, we were admitting all COVID and not regular cases. And just last week, more of the traditional medicine cases, have come into the hospital, and COVID has decreased.
I think since this is a major issue, so we were also kind of looking into the solutions for that, and I'll take a minute for that. I think what were the solutions? I think obviously, the patients, those who require urgent attention, how can we help them? So the one option, obviously, as I said, is the telehealth or the phone consultations, which is really not working well, as I said, for us at least. The other thing we were thinking was that, unfortunately, all these sicker patients actually would require to go to tertiary care centers like ours or maybe yours. But then these tertiary care centers, again, are the hotspots for COVID-19. So that is a problem. So there's an issue, or there's a fear of the patients actually getting in, and the risk of nosocomial infection. So I think the one way could be that, again, some of the guidelines did suggest that you can have a clean facility or a dirty facility or a COVID facility. But then again, I think that may or may not be possible. And the issue of asymptomatic carriers again would be stay. And the other policy which we were thinking was that before we start seeing these patients and start helping them, can we test everyone? Again, I think practically it may not be possible. Antibody testing, as and when the reliable one comes in, we may be able to do it. Or maybe, you can do a RT-PCR a day prior to their clinical visit. I think it's again an open question. And lastly,
I think the concept of having, it's great to have a COVID negative hospital, but I think in the end, it's going to be having a section of your hospital that's going to be COVID free. And then it's a question of, is the COVID generating around the rest of the hospital, or the people at risk? So you're still going to need good PPE. But so we're looking right now, since we're a very large health system at 23 hospitals, is designating one hospital as COVID free and doing elective surgery. In New York, you're not allowed to do elective surgery yet by decree of the governor. But, Dr. Shiano, Tom, has been able to keep a COVID free unit to try and keep transplantation going.
And
forward.
lastly, I think, Neeraj, you said about the transplant thing. I think because of all these issues, the problem is that we have only the DDLT program at our hospital. Now, how do we admit our patients? There's a problem with the beds. Our ICU is full of because of these patients, end-stage liver disease. How do you work up your recipients for transplants? And even if, you need, the support of other departments, maybe radiology or cath lab or what. So how do we do that, number one? And even if you're able to do it, I think, how do you perform the surgery? Where are the OTs and the ICUs and the ventilators? And where is the blood? The transfusion medicine is facing a huge struggle these days. There are hardly any donors. So where is the blood? So I think all those resources which we are, kind of constrained, I think I have to tell you the truth, in the last 3 months, we have not performed any liver transplant at our center. Otherwise, also ours is a low volume center, but then because of all these logistic issues, I think we are finding it very difficult.
Yeah, I totally agree. I think in general, logistics are extremely difficult for carrying out a liver transplant. On that note, I think we should probably end. I would like to thank all the speakers, Dr. Soin, Dr. Schiano, Dr. Tepperman, Dr. Satpathy, Dr. Duseja for joining us here and giving your valuable inputs and experience. Let's hope that New York has seen its worst, and hopefully I think you're in for better days. India luckily, Touchwood has not done too badly. Let's hope we be that way and we can all get back to our normal lives and our normal daily schedules. With that, thank you, everyone, and thank you for joining. I would like to
Thank you,
Bye,
Neeraj.
bye,
Thank you.
joining us. Have a great day in the US and a good night to everyone in India. Bye-bye.
Thank you. Thank you very much. Thank you.
Thank you.